Dear audience and hello everyone. I'm Kuo Hsin Hong from Taiwan. I have seen a lot of my mentors today. It's really honored for me to share with you my experience, and I will share from a gynecology endoscopist viewpoint. How do we select the patients for HIFU? And I also try to keep things as simple, of course, and I have learned from Professor Hu how, well, I will just share with you from the top level, so from the basic level, hopefully it can be useful for beginners. I'm from Taiwan, Zhongli Hongqi. I also have some roles in different societies. I have experience in various areas such as microwave and ablations or other types of technologies. So this is a background. There's no financial support, and Taiwan, there's some expenses and differences with mainland China, so that's why there might be different practice. HIFU's fee is higher in Taiwan. That's maybe the reason why it's not that popular. And then from the gynecology endoscopist view, I would like to share with you about the current practice. There's no laparotomy, and even for those extensive or localized adenomyosis, we still treat with HIFU. So I will focus on three aspects. The first is contradictions. Well, if there's contradictions, then do not perform HIFU. Then the rest can be done with HIFU. And then what are the factors that would have a poor prognosis? We need to avoid that. And also, we need to have wisdoms in counseling to convince the patients to use HIFU. So contradictions: one, uterine sarcoma; second, poor acoustic pathway. Well, as for sarcoma, and I heard some doctors mentioned about uterine sarcoma, but we need to break it down further. MMT, this is a carcinosarcoma, and second is leiomyosarcoma. ESS and also undifferentiated carcinosarcoma is more rare to see. So MMT and leiomyosarcomas, and I'm confident to be able to treat with HIFU, but of course not 100%. We need to screen patients first and then make choices for surgery or HIFU. So MMT, that is a carcinoma. That's the I think this they grow on uterine endometrius, and you can perform tests, and then you can do target biopsy, and then you'll be able to treat them. So many patients have vaginal bleeding or abdominal distension, and then leiomyosarcoma, that is a headache. So basically, it's just the same like a benign sarcoma. So imaging is important to tell the difference. Of course, and compared with other experts sharing, and this might be just a part of the iceberg, but there are many of the images can tell those leiomyosarcoma. So there is an irregular, heterogeneous, central, hyper intense, look like a cloud blowing the wind. I told my students we need to tell the imaging of a cloud abroad in the wind. Also, it's like an ejecting gas. If such images can be told, then it will be very precise in diagnosis. So you can see sometimes the imagery you cannot tell clearly, but now here's another topic. So those are the late sarcoma. But is this early one sarcoma? It's a question mark. Is it so what are which are sarcomas and which are not? Well, because normally we use ultrasound for examination, and it's not possible for MRI for each person. Now let me tell you that all of these are sarcoma. I think you don't have much problems with the top line, top three. So you know that the symptoms are strange and an MRI would be needed. But underneath, those are early sarcoma for me. So that may be overlooked. So many images would miss early sarcoma. Well, if it's advanced stage, it won't be missed. So this is one of my mentor who joined. So the previous two are the early stage and early sarcoma that can be easily missed. And the key is how to identify those early sarcoma. So we would find some unexpected leiomyosarcoma in surgery for endoscopy list. We know there's a doctor from U.S. and in 2009 used a HOMA with a poor prognosis. So it was banned. FDA had statistics. If it's a leiomyocyte, well, it's 1 out of 352, and an AAGL, so 1 out of 585. Well, it's different from what we see when I go for a meeting in Japan. It's 1 out of 1,681. Well, MRI is like 3,000 Taiwanese currency, but in Taiwan it costs several times more. So a high ratio of a preoperative MRI, 100% in hysterectomy and 99% in myomectomy. So that's why radiologists are being trained with imaging technologies. Many high FUAS experts saw MRI, just like Professor Gong Chun-mei has shared with us excellent imaging. So non-typical, atypical tumors can be identified. Then the misdiagnosis would be decreased. And we also often see MRIs being used in many hospitals, and so Director Ying Jiji has drawn a conclusion. Well, for benign bilirrhosis or at least a stump, we need to negative predictive rate is as far as 96%. So this excellent data tells us if we say it's not cancer or sarcoma, then 96% of accuracy can be for sure. So there's nothing much to be discussed. If MRI tells it's malignant, and Actually, positive detection rate is only 88%, and there's still about 12% of possibilities that is not malignant. However, many of them still went for surgery. For MRI, or cut rule stamp out, so this is the third type, and then we need to consult with patients. Some patients want to bear children. We need to select that treatment and carefully for them. So maybe some misdiagnosed sarcoma for HIFU, but anyway, we can revise and reverse it. So this is the third class that I put. Well, these are my logic instead of ADC values. And so for beginners, and it can help you to reduce misdiagnose. So 96% and 88% of negative and positive ratio. Then how can we find early sarcoma? Well, actually, I don't use imaging to diagnose, but we focus on symptoms. I will pay special attention to the following symptoms. Rapid tumor growth, double size, and within 3 to 6 months, or growth even with a GnRHA. So then the possibility of malignancy is very high. So as long as an GnRHA is used, and then you pay special attention to it. And MRI would be needed, and talk with some patients. Tumor growth even after HIFU. Remember, in follow-up, if there is a quick tumor growth, we still need to treat as a malignancy. Then also blood sample is very important. CA125, Fisher, and LDA is high, grayscale ultrasound, and then suspicious symptoms, arrange MRI. So following these 3 principles to rule them out. Remember, contradictions, and it's an uterine sarcoma, then no HIFU. Poor acoustic pathway, no HIFU. So you are our experts, and so I will be brief. So this one is poor acoustic pathway. And as we know, the root tissues and bladders is the best.
If the acoustic pathway is not good, then should we just completely avoid the HIFU? Not the case. We would like the patient to do the bladder exercise, and so there are also some chances for the poor acoustic pathways as well. So here, let's take a look at this. If we would decide to do HIFU, which factors will just influence the efficacy of the HIFU? We hope that the HIFU could lead to a good prognostic result, and so we need to just select the relevant standards to measure the efficacy. And pitifully, the Zhang Lian has just left it here. When I was studying in the Zhang Lian's hospital, and that training is very important for me. That training has led me that now that she's a very experienced doctor, I should just learn from her. And if I can just if the HIFU could just finish this operation within 57 minutes, now we'll transfer from other modalities to HIFU. So this training course has raised my interest, and yes, before the operation, we will take a look at the T2 signal, and also with the angiography agent, it is not so bright, and 57 minutes after that, we can see the the ablation time is the 400 seconds, and also the another the parameter is the volume reduction rate. We just calculate the volume reduction rate the 6th month after the operation, and so here we got the data. I just very appreciate the slides which has been presented by Zhang Lian in hospital, and she just they selected the nearly 800 patients, and the volume reduction rate is the 80%. We can see that this has the certain rule for me. If I just can follow this process, I can just realize a very standardized procedure, and we can and before this, I can see that according to my HIFU data, the volume reduction rate is the 94%, and no edema of the skin, no damage of the bowel, no damage of the bladder. So I just started to completely trust the HIFU. And after knowing these standards, we'd like to know how should we just raise our standards. And first of all, we will see MRI the signal, and we can see the MRI signals of the skeletal muscles, and these are the type 1, type 2, and type 3. And in Zhang Lian's research, they call the first type 1 hypo, and the type 2 means the poor level or the lower poor level signals and lower signal, and the type 3 means the high signal. It means so, and the type 3 has the worst HIFU effect, but it's not the 100% sure. So, and if the patient has a good tolerance, then it is okay. And next, let's take a look at the reintervention rate. And somebody thought that the reintervention rate of the HIFU is high, but actually it's the post-operation, the reintervention rate is very low, as low as the 20%, 5 years after operation. If we just take a look at the reintervention rate, first is age, if the size. Watershed is the 5 to 6 centimeters, and also a type of the myoma matters. If it is so this is what I will just discuss with the patients and determine and predict whether or not the reintervention rate is higher or lower. And here, if we can, let's take it, if it is located close to parameters, then the reintervention rate is higher. And if it is deep, reintervention rate is high. And if it is closer to the abdomen skin, the reintervention rate is very low. So we can see the position and the size of the tumor. We will see the reintervention rate, and also quality of treatment is also important. For example, here, this is the very shallow myoma, and if it is deep inside and it's very close to the receptive nerve, that would just cause the low quality of the treatment. If it is close to the navel, there are a lot of the residual end of the nerves, or it's closer to if it is closer to the the bones, then it is not easy to just operate the HIFU, and the quality is low. And but if we can just control the energy of the HIFU, then the efficacy is very good. And also the fatness of the abdomen, and also the patient has the very serious has a very has undertaken the surgeries on the navels during the childhood. So we just made some readjustment of the acoustic pathway and just did the HIFU, and the result is very good. He's very thankful. And also the patient selection. About patient selection, and I will just try to just skip this section. Okay. Okay, thank you, Alison. And actually, for the kind of for the for the uterine myoma at this size, it is still possible for the patient to get the pregnant and after the HIFU. And we just did the HIFU on this the patient, and finally this patient got the pregnant actually. So we can see the HIFU could have very good the prognostic the result, and after and some and the some also said that after the HIFU, some patients just used the IVF, and the patient got the pregnant, but many the patient doesn't need the IVF, and so I want to say that the age of the patient is also very important. After the HIFU, for the patients under 40 years old, they can still get pregnant after the HIFU. If they are over 40 years old, they must just do the IVF after the HIFU. So age is important. And also, how should how should we persuade patient to do the HIFU? And now in Taiwan hospitals, no aesthetics doctors, and less inpatient time is also requested. So in this case, by using HIFU, the patient doesn't need to just do the inpatient process. So in Taiwan, this is the case. So HIFU just saved a lot of troubles. So we can just should we persuade more patients to just focus on the HIFU? First, we should talk about the cost of the non-invasive operation. Speaking of the cost, if the cost is very low, if the HIFU cost is very low, then the patient doesn't have the higher expectation. Unlike in Hong Kong. In Hong Kong, the cost of the HIFU is very high, so patients have the high expectation of HIFU. About the reoccurrence of the myoma, it means that the myoma has not completely removed. So the old residual myoma will just grow into a bigger myoma. A second type of recurrence means that the new myomas will just grow out of the nowhere. So by doing HIFU, there will be some residual lesions inside the patient. So in terms of the recurrence rate, I believe that the recurrence rate of the HIFU is just a little tiny bit higher than that of the minimal invasive operation. So if the patient wants to consult with us on this, so previously, so we will just suggest the patient to do the evaluation of the acoustic pathway. And second, according to the age of the patient, for example, and also the size of the patient and depth of the lesion, and whether or not it is on the lateral side of the uterus, and whether or not it is on the posterior wall. If yes, we will not I would not recommend HIFU because the effect is bad. If the patient said, I want to just get pregnant in the future, so I will not just I would just be discreet. And some of the patient in Taiwan, the cases like this, although if the patient is young and even though the size of the lesion is big, and they still want to get pregnant, if there is the malignant, we would just refer this patient to the gynecological cancer department, and also during and also we can see the position of the lesion is also very important, and also for some patients with the scars of the previous operation, they can still undertake the HIFU, and several years ago, I started to just use the kind of the drug which is called the estrogen to the which is the misoprostol. We just let the patient to take a misoprostol before the HIFU, and we just carried out the comparison. And these two groups are the groups with the misoprostol and without the misoprostol. So we can see that the time of the radiation and the treatment time and sonication time, we can see that the data is very good. I can just do the operation very fast, and we'd like to say that this is the very lazy treatment, lazy version of the treatment. So if we just administer misoprostol to the patients, then it is easier for us to do the HIFU. And finally, I'd like to say that the average MPA is higher than 93%. Okay, this is my sharing. Finally, I want to say this is all about my sharing today. Thank you very much.